Good morning, everyone. I'm going to let folks get settled in here before we kick things off. Really happy to see so many folks joining us this morning. It's great to see you guys. It's a balmy 6 degrees here in Iowa. I don't know if you guys are probably a little colder up that way, but you can tell me how cold it is and I'll feel a little better. About 6 degrees down here. Great to have you all here. Let's see, we've got a few people still connecting to audio. Let's give them a chance to get settled in virtually, and then we'll get started. And I'm going to go ahead and disable the waiting room so everybody can get in. There we go. Okay, yeah, I've disabled the waiting room, so everyone should be able to join, even if they're joining a little bit later. And we've got a few still connecting to audio. Let's give them a chance to get settled in, and we'll get started. Yes, I see Katana's telling me minus 17 without wind chill. Wow. Yes, thank you. Thank you, Katana, for making me feel so much warmer here. Okay, looks like
we're 0 right here, Steve.
Are we still 0? I thought we were.
I am, yeah. I think you're a little bit up there, but a little bit higher.
Yeah, we're a little further up, a little further south, maybe. Yeah. Okay, it looks like just about everybody. Looks like Dory's still trying to get connected, but I think everyone else is plugged in. Oh yeah, I've got reports of 3 degrees there. That's an improvement. Well, once again, I want to say good morning, or perhaps good afternoon, if you are in another time zone. But I'm going to say good morning to everyone. My name is Steve Steiny. I'm with the Native Center for Behavioral Health here at the University of Iowa at the College of Public Health. We have been working collaboratively with Donna Enfield and the Bemidji IHS region to bring you this ongoing series, behavioral health series, Walking in Two Worlds, Behavioral Health Challenges of Living Native in a Non-Native World. This is session 7, and I have with us today our presenter and speaker, my colleague and friend, Mr. Sean Bear I. He's got some great information he's going to share with you guys today to address this topic of stigma across context and culture. So I've got a few introduction slides we'll go through, and then we'll transition and pull up the next slide deck, and I'll turn the floor over to Mr. Bear so he can get started. But again, I want to just welcome everyone. Please get settled in, close any other programs you've got going, and really just sit back and be with us for the next, next hour and a half. I know Sean and I talked before the presentation today and earlier this week, and we're hoping to have some time at the end to maybe take questions or have a dialogue with all of you. So keep that in mind as we go, and I'll try and watch the chat box as well. You can use that if you have comments as we're going, and I'll try and come back to those. If you have a question for Sean or a comment, I'll try and come back to those once we conclude the presentation. So anyway, this event today should run until 11 a.m. Central. So let's get started. Again, great to see everyone, and thank you so much for joining us today. I know Donna could not be with us today, but she wanted me to let you all know that she's with us here in spirit, and just couldn't make it today to the presentation. So let's get started. This project is supported by the Native Center for Behavioral Health in the University of Iowa. The content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of the Native Center for Behavioral Health, College of Public Health, or the University of Iowa. Following today's event, we will make available to you a PDF version of the slide presentation, and we are recording this event, and it will be available as well on our Native Center for Behavioral Health YouTube archive channel. We can make those links and information available to you post-event. We'll also be offering NADAC approved CEUs, or 1.5 CEUs, NADAC approved or social work approved CEUs through our Iowa School of Social Work. When you receive your follow-up email, you can request either NADAC, substance abuse CEUs, or social work CEUs. I know we're gathered here virtually today, but we wanted to take the time to acknowledge the land and pay respects to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll, and our co-director, Mr. Sean Bear. Thank you. Well, without further ado, I want to introduce our speaker today, Mr. Sean Bear the First. I've known Sean now for since January of 2019. So it's been, gosh, Sean, has it been 3 years already? Wow. Sean is our co-director. He has a lot of experience working in the behavioral health field and has served as our co-director for several years. He has a BA in psychology and human services. He's also a U.S. Army veteran and has worked in a variety of different settings, as I said, both working with youth in substance abuse services and in-home family therapy. He has experience in building holistic Native American-based curriculum and implementation with substance abuse patients. He was the training coordinator for our center and is currently, as I said, serves as our co-director. So I want to introduce my colleague and my friend, Mr. Sean Bear. Sean, I'm going to just transition here and pull these slides down, and then I'll turn the floor over to you. Just give me one moment to get the next slide deck up, and we'll continue to go from there. Let's see if I can make sure I've got the right deck up, and we'll get started. Okay. Let's see, I'm going to take that old one down. Just bear with me, folks. We're almost there. Okay, here we go. Now I'll put this into, there we go. Are you all seeing now the full screen? Okay, I've got thumbs up here. Thank you, Petriana. I appreciate it. Okay, Sean, I'll be advancing Sean's slides, so he'll just be prompting me as we go through the slide deck. But I'll now turn the floor over to Mr. Sean Bear. Sean, thanks so much for joining us this morning.
Thank you, Steve. Welcome, everyone. Yeah, I'd also like people to know that I had also 2 years of voc rehab and licensed mental health counseling education, which I'm still trying to finish. So we'll see about that later on. Yeah, after the military, well, before the military, before I finally had my final discharge, I was with the 82nd Airborne. Just a little bit about myself. I'm from the Meskwaki tribe in Tama, Iowa. It's nice to have you all here. Thank you for coming. Okay, next slide, please. Okay, so when we're looking at a lot of this here, we're looking at a lot of stigma, stereotypes, and kind of bias across of other cultures, and sometimes even within our culture. As you might know, it's like sometimes when we even have our own culture in our communities, what happens is usually tribes are fairly close knit. Everybody kind of knows each other. But even those who end up going to school, maybe they have to go away for a while, usually end up having something going on too. And some people will think, oh, this person's think they're better than everybody else. But again, that is just a very subjective ideas coming from that is not from the person themselves. And looking at this, I mean, while we do have stigma, there are problems of like dropouts. Maybe people look at them as looking unmotivated. Natives may have more no-shows, maybe a little late or something like that. But a lot of that is also part of our culture. It's not always by a certain time, but when it's time. And a lot of times when people are late, that it has more things to do with what is going on within the family than it is with anything about treatment or anything like that. Okay, next slide, please. So this here, I really want to let people know within the brain, it regulates things. It wants balance. A lot of times when people put substances into their system, some chemicals boost up higher. And what happens is, it's just like when people say in the past, it's like people never get the same kind of high or anything like that than the first time they use. And that's because normally what happens is that dopamine, serotonin levels boost up very high. But we need to remember that within this system, serotonin, it's a neurotransmitter, it regulates mood. So, and dopamine is a feel-good neurotransmitter. So what happens over time, since the brain wants everything to be balanced, it lowers like from a normal level to go down. But eventually what happens is it also is changing the way that these neurotransmitters operate. So by the time somebody gets into treatment, what normally happens is these have been, you might say, hijacked or something like that, because you have receptor sites that are closing down. You have higher levels of dopamine, serotonin, even the reuptake is kind of changing. So you're even flooding the system more with serotonin and dopamine. It doesn't mean they're all going to get through. And looking at receptor sites, each receptor site is almost like uses a different key. So it needs to be able to plug in just correctly. So that's normally why at times they need some kind of a medication in order to help that. Okay, next slide, please. So looking at the history, kind of, or the significance and how complex it can be, is like we also need to look at histories of physical and sexual abuse, being abandoned, lost. They could be very traumatic. But remembering that, looking at Native Americans, we also have this compounded traumas that are being associated with it all. Now, there are historical intergenerational trauma. Remember, this goes back hundreds of years. And what they found out is that during this trauma can pass on from generation to generation. But remembering with different peoples in the world, it's more of a historical intergenerational trauma because it's many, 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 many generations. So over time, it's been passed through the genes. And a lot of times, though, when you're looking at trauma, this intergenerational trauma, it's not just affecting the person itself, but the community. So, and it also, like, things have been lost. Maybe there's certain teachings around certain things, but the knowledge of that is sometimes lost. So they're trying to figure out, how do we get this back? You know, and the way that I was always taught is that no matter what's been lost within a tribe, they can always return. But the way I was taught was that you always need to fast to be able to bring those back. And sometimes you can fast 20, 30 years and not get what you would like, but you get what you need. So, okay, next slide. Okay, so when you're looking at stigma, substance use disorders are among the most highest stigmatized conditions in the world. So a lot of times people looked at as a perceived control that people have over the condition. And remember, you need to look at this as kind of like diabetes, how people sometimes they may relapse and have a piece of chocolate. Well, in that case, you wouldn't kick somebody off out of treatment just because they had a piece of chocolate or a piece of cake. And that's the same way you need to look at substance use disorders. So they look at the person, they have a fault in them acquiring the condition. There are also those that say that, I think we'll talk about it a little bit later, but okay, go ahead, next slide. Okay, so for people with substance use disorders, mental health diagnoses, stigma and other cultural differences, they disproportionately influence health outcomes and well-being. Now, we need to also look at some of these assessment processes, things like that, whether it's substance abuse, mental health, because a lot of times what happens is that not everybody knows all of the cultural differences that are included in one tribe, and they definitely wouldn't know all about these other tribes. So that can influence kind of a bias. So what happens is many people might see that what a client or patient is saying sounds odd. Well, that's normally because it's not part of their own culture. But the clients, we need to look at the client's culture. We need to look at the community's culture and what's going on, because even within looking at community and family and individual, knowledge can also be different. So a lot of times what happens is clients or patients may have fear of being judged or discriminated against, and that can also prevent them from getting the help they need. This fear of being judged by stereotypes, and a lot of times stereotypes have developed from outside our own culture, may affect them. Okay, next slide, please. Okay, so stigma can also prevent caregivers and others in the position to help for providing needed services, including medical and mental health care. Stigma may prevent mothers who use drugs by accessing prenatal care. A lot of times what happens is during this, it's like when you're looking at it, I've seen a lot of people within Native communities that they are worried about going into even their own substance use programs, especially with even going to medical or mental health. I know when I was growing up, a lot of what we had learned growing up, we were told not to tell outside people because they would misinterpret or misperceive our messages and think something else about it. But we need to remember also is that these professionals need to look at these things from our point of view, not their own. A lot of times mothers might be worried about the way that we raise our children. Looking at a lot of America, they have what is called the nuclear family system. And this is not a Native American system. On many Native families across the United States, there might be a few generations living in one household, and that's normal. There are different practices. I mean, a lot of times it had always been grandparents who had taught grandchildren the older ways and things like that because they have more of the knowledge to do so. So a lot of times they also became caregivers. Just as long ago in one community, it was up to the whole community to be able to teach children and what can be done and how things really are, where they came from, the history. I mean, when I was growing up, one of the first things I had to know was who are my relatives? Where does each family come from? What is the history of each family? Later on, so that when I'm growing up, I would know these things. Okay, next slide, please. Okay, so also we have substance use disorders, opioid use disorders. They carry a high burden of stigma. Remembering that what is being found today is that people who experience stigma are less likely to seek out services. When they do experience stigma, they're more likely to drop out. Both these factors compound and lead to worse outcomes overall. So a lot of times what we talk about within counseling is that we need to be able to look at every person individually and not to judge what they're saying. Remember, we must look at their culture and how they've been raised, what has been going on with there, because everything that we may think of from our own cultural point of view may not be relevant to what is happening with our clients. Okay, next slide, please. Okay, so here's a little bit about stigmatizing and non-stigmatizing language. Now, I know that there are times when we might have counselors or people like that. I mean, I've heard it myself, is that talking about a client as alcoholics, addicts, junkies. I've heard even counselors say that people on methamphetamines are just paranoid. I've heard that people who use opiates are just making up the pain because they just want more of the substance. I then began to I took it upon myself to teach them more about how to look at things. And so we're not supposed to use a person in recovery or a person who has not stopped using yet as alcohol junkie or anything like that. With people on methamphetamine, I had to let them know that, you know, some of these chemicals are also interfering with that and causing paranoia. It's not about them just being paranoid, but they've also put themselves in positions that it is more dangerous. Like, for instance, if they are around like dealers and things like that, I mean, looking at further and further, it can be dangerous. A lot of times those who use opiates, well, they do feel the pain. And it's just that they feel it more than they normally would because of what is happening with their neurotransmitters and chemicals within their body, because it's being altered. Some of the rationale for this is that it's not right to define a person by the disease or by the drug. So we need to look at things a little bit differently when we're working with our clientele or patients. Okay, next slide, please. Okay, so here we have this another part about discrimination, but it's going a little bit more into working with Native Americans. Remembering that with stigma stereotypes, a lot of people don't always understand that those who live on tribal lands, the Native Americans who live on tribal lands, are more likely not to use substances than any other ethnicity. Because a lot of times people said, no, Native Americans are prone to developing substance use disorders or something like that. But we need to remember that they found out that more natives living on tribal lands are less likely to use substances than any other ethnicity. Now, also within tribal lands is that the way that we're taught many times within our traditions, spiritual practices, medicine practices, that these are also looked down upon, is that they're not to be used around our ceremonies. They're not to be used in walking, you know, kind of like the red road or a good road in life, that it doesn't mix. It's not part of our way. So it's something to be able to take into consideration with that. Most studies in the past that have worked with Native Americans and studied, and their research were done in urban areas, not in tribal lands. It's recently that they began to look at more studies into tribal lands because they wanted to find out what many people are already saying, is that's not the way it is on tribal lands. So I'm glad that they began to do more studies with tribes. And many times it's happened that tribes do not always trust research. Long ago, they used to do what they call helicopter research. They'd come in, gather this information and leave. Well, without even consulting back with the tribes or the natives, they went back and wrote something that may not even reflect what the tribal peoples had said to begin with. A lot of studies may say that, like with medicine peoples and healers, spiritual practitioners and stuff like that, is that what they're saying is that these people do have knowledge of behavioral health or mental health, and they're just pretending or tricking people into believing that they're being healed when that's not normally the case. It comes from like a bias in a sense of how others might hear what we're saying, but not really understand it. Okay, next slide, please. Okay, so this is something that I kind of picked out because of the way many people believe of where natives came from. But we also need to remember that there are studies in a sense that follow other rules, and there are like where people get together and say, well, that doesn't reflect this study. But it doesn't always mean that all things are always true in what people have learned before. I mean, there's a lot of research that has been done, and like in the Appalachian Mountains, they found remains of a community there where that was like 55,000 years old. There are those down in the Southwest that was 130,000 years old. There are those looking at Beringia as saying they only came one way and it was always coming east across there, but they don't really have the evidence saying that they actually came east. They could have went west. I mean, but over time, things have changed. So there's always these different kind of theories, he said, because Beringia is a theory, not fact. They haven't found it to be factual yet. I mean, it's still theory. But Turtle Island and our creation stories also tell us a lot about things. Many people might look at certain creation stories from only one part of the world, or maybe a couple, but they don't always reflect how indigenous peoples think across the world. So long ago, the way that many of us might be taught is there was only one landmass long ago, and that was Turtle Island. I mean, and a lot of those very first stories and teachings that were being shown to others came from more of the Algonquins. And that's what they had been talking about then. Even that's where a lot of the seventh generational prophecies and things came from. But later on, we're hearing more from those that have lived within the central United States and stuff like that, where there is no water like that, all on a coastline. So of course, the way that they might see that or hear that might be different. There's also part of how humans came to be. Well, it's a lot of our stories say that we weren't human like beings to begin with. We began as spirit, and that in order for us to grow even faster on that side, we had the opportunity to become physical beings. And the way that how we see the spirit world to the physical world can be very different, especially in time reference, because the time is not always the same as it is for us on that side. What they say is that, well, there's different, of course, you have to look at different communities, different tribes and stuff like that. I know here we say that for every year here is only a day on that side. And what I really like about that is I see Alaska as like that same kind of format there as spirit time, because they have a long period of darkness and a long period of light. And that is, like, to me, looking at more of the spiritual time and how that kind of operates there. But there's also things with animals, nature, and life. We learn to respect that, and that there are life within every one of these. You know, the way that we see spirit might be different. And that is something that's really been kind of coming about over the years, is that Native Americans seem to have some kind of innate ability to see, hear, and sense things that not everybody does anyway. And that's one thing that's on different questionnaires or assessments that is not accurately defined within our culture. And it's something that's not very culturally respectful for us. I mean, there was studies back in, I think, the 80s about what they called the split feather syndrome. And all these children that were taken from the tribe placed in foster care. Many of these were later, while with the foster family, the family seen them as acting oddly. So many of these were taken into mental health for mental health assessments, and they came out with some kind of mental health diagnosis. But later on, they want to find out why this is happening. So they went to study that, and they found out that even these very small children who would not remember being taken from the tribe were also exhibiting the same kind of innate abilities to be able to see, sense, hear things that not everybody did. But they were also following in line with tribal practices from their own community areas. And remember, community, family is very important when you're looking at a lot of diagnosis and things like that. Okay, next slide, please. Okay, so here's this kind of thing we used in some of our trainings. I mean, first there was, you might see this along in the Minnesota Native American curriculum training that they have out of Minneapolis. That was the second one built. The first one was built out of in South Dakota. So it was a South Dakota Native American curriculum for non-Native professionals work with Native Americans. But along this case, looking at traditional, bicultural and assimilated, not everybody on the tribe is going to be actually the same. So we need to look at everybody individually and finding out where they are first. We might ask them if they are more traditional, if they have been more assimilated or bicultural. The traditional peoples, they may do things a little bit different. Maybe they take more time to think about their language before answering. So there might be more pause. With more assimilated peoples or acculturated, they may answer right away. They may be more aggressive. They might talk more. Bicultural can be kind of in between. Maybe they have different things of each one, but that is dependent upon, different factors within the tribe as well. The traditional people may have more knowledge of their cultural practices. Okay, next slide, please. Okay, so here is a little bit about breaking down a little bit more with traditional, bicultural, and acculturated. Eye contact within traditionals might be more indirect, so they might not always look at you in the eye. Bicultural people may be direct or indirect, and more acculturated or assimilated people might be more highly direct. So it goes on the line with handshakes. With traditionals, non-aggressive, communication is reserved, emotions are more reserved. That's why they kind of get the stoic Indian kind of look. About anger is usually suppressed or subdued. Eye contact, handshakes with acculturated or assimilated people might be more aggressive or highly aggressive. Communication might be verbal or highly verbal, and they may capitalize upon the conversation. The emotions might be highly outward. Anger might be expressed or highly expressed. So the bicultural kind of falls in line with in between these two. They could be closer to one or the other. So when we're looking at people, we also need to look at how they also describe themselves, how they might see themselves from others within the community, maybe how the community is. So there is very different variances in this. Okay, so next slide, please. Okay, here's a nice sample identity assessment question. These are kind of like a questionnaire. We need to be able to ask each client is, how do you identify yourself? Are you traditional, bicultural, assimilated, or acculturated? Do you have any other ways that you identify yourself? Do you identify yourself as part of the community? Do you identify yourself as a little outside the community? Are you okay with how you identify yourself? That's looking at them. Are they okay with where they feel they are at that time? How do they feel when they're thinking about maybe how they're seen by the community? How do you think your friends would identify you? How have you ever experienced any feelings of inferiority related to your ethnic identity? If so, how has that affected you? Remember, this could also be within the tribe. It could also be outside the tribe, in the community areas and schools, or in businesses, or even to the grocery store or something like that. And then asking about, have they ever experienced prejudice from tribal members or non-tribal members? Sometimes there can be, they can feel prejudice or feel they're experiencing stigma from even within the tribe. So a lot of people don't always understand. So, okay, next slide, please. Okay, so this is something that is used pretty much in a lot of Indian country. It's the Red Road approach. In the beginning, this had come from the Red Road kind of a bunch that was working out in the Dakotas. Later on, it's like, I know that some of this was also bison and then used in their things. But it's a kind of innate cultural, spiritual resource for indigenous peoples. The Americans, they're to focus more of the Red Road approach into treatment. Culture and spiritual information are normal part of treatment regimen. Remembering that when we're looking at things, it's good to be able to add culture into our treatment programs in the way that we work with clientele, because in many cases, going back into our cultural events or tribal ceremonies, spiritual practice, stuff like that, it can take people away from the use, because it doesn't really match well. Substance use doesn't really match well with those practices. A lot of times you see that when somebody does start to use substances within the tribe, people from maybe where they went to ceremony or spiritual practices will notice they're not there. And so a lot of times what happens, they might say, "Where have you been? I haven't seen you for a while. What you been doing?" And it's hard for them to kind of answer. So over time, they begin to stay away from them people. And later on, it might do the same with the community and family. So what happens is, through that process, you're losing your spiritual kind of group, then the community and how they might see you. This kind of fear of that being kind of judged. And later on, a lot of times they might begin to isolate. And so it's really good to be able to jump back into things and get back in the swing of things. So that can be very helpful. Okay, next slide, please. So indigenous knowledge, we also need to look at local knowledge. The local tribal knowledge is unique to a given tribal culture or society. It is its own theory, philosophy, scientific and logical, has its own logical validity, used as a basis for decision-making for all life states. I know that at one time, because at times I'm asked to go help some people that are going to see a doctor or psychiatrist or anything like that, because they're afraid of being judged by outside assessments, and looking at our culture. What happens is that in the past, some of them had said, well, I've worked with these tribes, across the country. Maybe there might be a Southwestern tribe, and saying that, well, I know how to work with Indians. I worked with Indians, so I know how to do this here. But you have to remember, like within the DSM system, the DSM-5, it says that if you do not understand this culture here, this family, this client or community, you must ask people from where that person is from. If you're not sure, ask the client's family, and then the client's community. You don't base their culture upon a whole different culture across the country. So that's something that needs to be looked at a little bit, because sometimes they kind of think, many people might think of Pan-American Indians, but there really is no Pan-American Indians. We are all very different, although we have similarities. Okay, next slide, please. So this is just a medicine wheel, and so we've used this. I kind of designed this because there are so many different medicine wheels out there. And some tribes don't even use medicine wheels. Some of them just have a circle, or they just have the 4 directions. There are so many differences within the medicine wheel that it's hard to be able to find a medicine wheel that works for everybody. But within this one is that you kind of reference all the different colors. The colors can be anywhere, really. And picking out the ones that work for a tribe, it might be very unique to that tribal practices. So we're not using the wrong ones, but also remembering that within this, it's like a life. Going all the way around is also a life. Looking all the way around is actually looking at someone holistically. You got your body, your emotions, the mind, spirit. So normally what happens is, in the very beginning parts of somebody's life, the body is growing extremely fast. They always say that if a baby kept growing at the level they were when they were very little, they'd be very much taller today. And looking at emotions, I mean, even teenagers have a very hard time controlling their emotions. That's why substances are very, I don't know, it's like almost life altering to many teenagers and stuff like that in those years up to about 25. Because during this time, remembering how the brain kind of develops over time, how it's maturing. And it's not later till that they begin to develop the part of the brain that helps them to regulate things a little more with the mind. So once they reach to a certain state, they're able to, they understand emotions more. They understand how it's influenced and stuff like that. So they begin to use the mind to mediate over emotions and the body. Later on in other stages of life, then they begin to master kind of the spirits, or the spirit part of themselves, in a sense, the spiritual life, walking that kind of red road. Okay, next slide, please. Okay, so looking at mental health today, and in the past, I know long ago that a lot of our ancestors here, our grandparents, great-grandparents, they had also always warned us about mental health, that they don't understand our ways, and that not to tell them things how things we do on the in our ceremonies, not to understand, they might not understand how we're able to see, sense, and hear things that others don't. I mean, a lot of times the medicine peoples are very much more so into that, where they can see, hear, sense things not everybody does. But there are times when even kind of people within the general community also do this at times anyway. But normally the medicine peoples and stuff are able to control that, and how that within themselves they can turn those off and on. So this is part of where a lot of those kind of beliefs and things came from. Is in South Dakota, Canton Insane Asylum, it was more run like a gulag in a sense. So in 1898, Congress passed a bill creating the first and only institution for insane Indians in the United States. What happened is that things weren't going well on there, and they found out that later on that many of these patients who were there didn't even speak English at all, and many of the people working there didn't speak native. So, and this was not just one kind of tribe. People from all over are placed in this asylum. A lot of times they were denied medical care. There was even times some were sick. They could have got a shot to help that, but they weren't given those. A lot of these people were actually traditional spiritual people. A lot of times they were just people who misbehaved or were within the different tribes. They were seen as troublemakers in a sense. And that was usually seen by people working within the tribes, because long ago, in many tribal systems and reservations, it was overseen by people meant to watch these natives and to keep trouble down, in a sense. So those who asked too many questions or things like that, they could be sent here. But the way this was seen as is that this Hiawatha Insane Asylum, Indian Insane Asylum, was seen as a death sentence because very few ever left. A lot of times when they went there, there was people would, the families and stuff like that would hug them and push them well, almost like they were just going to die. In some of the boarding schools and stuff like that, teenagers and small kids were threatened that if they didn't wise up, they would be sent here. So, okay, next slide, please. Okay, seeing how, in a sense, we look at mental health. On the left side here, we see this is kind of our Native American kind of assessment tools in a sense. Here on the right side, we see the DSM-5. There is another DSM-5 coming, which is going to be the DSM-5 TR, which is supposed to be coming out in March. So there is some changes, but we'll have to wait to see that till then. Okay, next slide, please. A lot of times when we look at those two pictures of, the shell and different smudging things, different smudging medicines, it might be cedar, sweetgrass, sage, or, maybe tobacco, or maybe something else that was maybe told to use, is that, the feather or different things that medicine people may use and a lot of times those come to questions. What are your dreams like? What's been going on in your life? What have you experienced? Have you seen anything? Have you heard anything? Have you experienced, certain things going on? Like, for instance, you turn on a light and all of a sudden it goes out, or you go by a light and it turns out. That may be something very simple to be able to ask them, and it lets them know a little bit more of what's happening in the person's life. Whether every time they go around a toaster, it blows up or whatever, it never works again, microwaves or whatever it is. I mean, that helps them to narrow down certain things. But within the DSM system, there is no culturally adapted mental health assessments for Native Americans. The DSM has not properly considered indigenous cultural beliefs and practices when it comes to diagnoses of mental health disorders. They had the DSM-4 and the DSM-5; those were the latest ones. Even the DSM-3, 1 and 2, but all those had not included indigenous populations, indigenous peoples, for their work groups. They had used either kind of people with family history in Europe or Latin America, or Latin. It was both pretty much Europe anyway. So they have this history, and more of their belief systems being used to be based upon other cultures. As many may be aware, there has been case of Native Americans and Metis peoples being diagnosed or almost diagnosed with mental health disorders based upon traditional beliefs and inherent gifts that they may possess. In our center, back in 2014, we began using roundtable discussion, and I was able to bring medicine people to this table in a sense, and we asked questions about people going to treatment, people going to mental health and things like that. There was many different questions I asked them. They would all go around the table and answer. But during that, we also see more cases where people in the medicine peoples were either diagnosed or almost misdiagnosed with mental health disorders that they didn't have. And a lot of times this came about from early on, like when something first begins to happen within a person and their medicines are waking up, it might be a very scary time for them. They may not understand what's going on. So, and long ago, there were medicine people within the community, and the community system was much more closer, that they would realize that what's coming or what's going to happen. So these medicine people would see the youth and be able to tell which ones they needed to look out for when they're older. Families more likely to go to the medicine person wanted to know what's going on. But today, the way it is that with many of the past histories, there's been many of our medicine people who have been taken away from the tribe because they were seen as troublemakers. They realized that leadership and the medicine peoples had a very big influence on tribes. So a lot of times they were taken away from the tribes. But today, there's been so much lost that not everybody always realizes that mental health disorders are not based really upon our own culture. And over time, many of the natives throughout our communities believe that they can utilize this same system to diagnose our own peoples. What they don't realize is there are still many peoples out there who experience some of these cases of sensing or hearing, or that not everybody does, within the cultures. And a lot of times in outside cultures, such as maybe European culture or Caucasian culture or stuff like that, is that they even recognize psychics now and looking at that, making sure that they don't misdiagnose them, but they don't realize is Native Americans are very close to that as well. So we need to be able to look at the culture itself that each person comes from, but remembering that not all things are always known today by every tribal member. The medicine people, spiritual peoples, Yes, might know more knowledge about those areas than some of the others. Traditional peoples might be very different from spiritual or medicine peoples. So they too might not always be able to give you the answers that you're looking for. Um, so it's very good to be able to utilize medicine peoples within our area to be able to look after and do a separate assessment with the person to find out if they are gifted. So it's something very important to look at. Next slide, please. Okay, so there are, remember, acculturation assessments like I went through before. So look at, allow providers to assess cultural identity of a patient, how they self-identify, as which can help the provider to gain a better understanding of cultural context and the symptoms are rooted. Additionally, whether a patient identifies as traditional, bicultural, or acculturated may impact their treatment outcomes or preference, because sometimes what happens is many Native Americans may want a more Native traditional treatment approach instead of outside the tribe. Rosebud, just a Rosebud personal opinion survey. This is one of them that had come about, if you want to look into that. Remembering that a lot of people with the Minnesota multiphasic inventory is Native Americans always scored higher than other cultures on that. Okay, next slide, please. Okay, the cultural assessment. Each person has a different understanding of their culture, like I was talking about before. Now we need to look at how they self-identify, look at what they believe, look at how much knowledge they have of their culture. That'll help to determine where he or she falls in the spectrum of acculturation from tradition to assimilated. In its basic form, this would include identifying the patient's tribe and affiliation. There are formal acculturation assessments that can use to accomplish this. 2 examples. Okay, but that's from a different one, I believe. Okay, next slide, please. Okay, cultural knowledge. Cultural knowledge comes from the community or family members. Remember that when somebody comes in for an assessment, we can look at them individually. But if we have question about their culture that we're not aware of, and if you don't take it like from the client's point of view, you can ask the family or the community. But remembering that not everybody from the tribe has the same knowledge level. So it's very good to be able to look out for medicine people, stuff like that, that can help with that. Remembering not to look at these from the professional's own bias, but to actually look at their communities' knowledge and their practices, not from another tribe. Okay, next slide, please. So cultural knowledge. There's traditional knowledge, spiritual knowledge, medicine knowledge, and it's not always known to every tribal member. Today, it's normally passed down from, and in the past, it's usually passed down from grandfather to son, father to son, teacher to student. But again, it could be grandfather to granddaughter, mother to daughter, or teacher to student still. But remember, it could also go from grandfather to daughter, father to daughter, or vice versa. But well, like the grandparents, might be a grandmother teaching a son, or might be a grandmother, father, or mother teaching a son. So remember, there are like spiritual medicine peoples, not just medicine men or women. So having been part of a ceremony does not mean an individual knows all that is needed within to do the same thing. There are so many different teachings, so many different things. Even looking at the sweat lodge, It's like a ceremony to gather the wood, ceremony to gather the stone, the ceremony to make the fire, ceremony in a sense to make the sweat lodge and how it's built and the design of that. It's normally all these teachings that go into that. So that way people don't run into situations like what happened down in Sedona. Ceremonies usually are consistent of many details. So there's so many different teachings to one thing. It's not always just how it looks. No amount of formal education teach you all that is needed to know to fully understand or be an expert in another culture. A lot of that comes from living within that culture. Becoming a student or living these ways takes many more years to learn than the highest degree one can obtain from formal education. Teaching and the teachings and knowledge that is needed to learn how to become, a spiritual person, medicine person, or things like that, even traditional person, takes a very long time to be able to learn a lot of these things. Next slide, please. Okay, so this here I want to show you is a case study. Now, it's an older person. They came into, they're older, hospitalized adult. They come to only speaking their first language from their tribe. Sometimes they may speak loudly to people when there's nobody in the room. They appear disoriented and confused, restless, agitated, not following directions, and behaving out of the ordinary. So by this person speaking, looking around, it appears as if she is speaking to others. Family interprets saying that she is seeing and speaking to past loved ones around the bed. Now, knowing this, we can look at this from a cultural point of view and also from a non-native point of view, because this isn't actually like part of a disorder within the DSM that is normal to our tribe. Next slide, please. Okay, so what they call this is delirium. It's normally the end of Alzheimer's. Alzheimer's begins, it goes into dementia, and the final stage is what has been recognized early on by nurses is what they kind of refer to as delirium. It's usually the end stages of one's life. The mental health perspective may look at this as delusional, perceptual disturbances, something going on with their language, and hallucinations. From a Native American traditional belief, it is a normal part of life. They are actually seeing their loved ones prepare, and they prepare them for the next journey to the spirit world. So it's not something that's going to be so abrupt they don't understand what's going on. And a lot of times with this, they may only speak their native language. So it might be important that somebody from their tribe is around. That's if they can even understand like some of these older dialects that they might be using. Next slide, please. So under this native thing here, we have native spiritual suggestions. Remembering this is a normal process. Don't speak about the patient where they might hear or tell the patient they are hallucinating. I mean, a lot of times we're always told before not to tell them these things. Suggest a family to the family if they're open to and may ask of the beliefs. These spirits are to get patient not to worry about moving on. If the person is worried about passing, they might be able to help them to reassure them that everybody in the family is going to be okay. Their worries will be handled. If they are afraid, you might need to ask of if they're open to this. Let them know that their loved ones are there to help them transition to the next world. This is more of looking at this from a Native cultural point of view. Okay, next slide, please. Now here's another case, and I wanted to kind of go these a little bit faster because I wanted to make sure we have time for questions at the end. In this one here, a patient was referred to the mental health program from the clinic. Patient presents with an account of seeing a dark shadow wearing a long coat, hat, and is very tall. Patient states that this began after being late one night out with his friends, yet patient states that other youth did not see him, but they said they felt a prickly feeling or shivers on their backs. Patients had begun to see this figure in his dreams and sometimes sees him in the corner of the room when the lights are dark or when it is dark outside, seemingly following him. Parents state that they have become concerned for him, but state it is uncommon for him to make up stories. So the clinic refers him to the patient for mental health assessment. And this, I like to say that both these cases are actually real. These are real cases. From there, they send him to a hospital for mental health assessment. Next slide, please. Okay, so what they called this was schizophrenia spectrum disorder. With the mental health perspective, they looked at the delusions, visual hallucinations, auditory hallucinations, anxiety, paranoia, possibly phobia. Within the Native spiritual beliefs, they looked at it as spiritual beings, and seeing that this person had a gift of sight. Okay, next slide, please. What it came down to was that what they were seeing is this dark shadow being. I've been looking at this from, ever since earlier 1990s. It's been talked about across many states and tribes. Many explain the same experiences. Many describe the same description of this being. Seems to appear around tribes with current suicide issues and seeks out gifted youth. Sometimes it might not be an actual youth, but even older, maybe in their 20s or so, something like that. But there are stories of this that have gone at least 4 generations. My mother spoke about my great-grandfather at the time had been warning people at the time not to be out late after night. I mean, a lot of times our people had practices that others might not always be aware of, but once it was nighttime, you had to be home. It was only later that people began to go out at night and stuff like that. But remember, this is across many tribes, not even just natives, but it's been out there. When we look at it, it's different. I know that I've talked to medicine people about it back in the earlier 1990s. They had referred some other people to talk to. They knew more about this than I've ever heard anybody else speak. Later on, I ended up meeting another medicine person who spoke about this, but he had more knowledge than any other that I've seen. And I know that in doing working with tribes who had suicide issues in the past, like they might see it as something, series of suicides going on, is that some of the medicine peoples had actually seen these things in ceremonies while speaking and trying to figure out what's going on with these people. I say people because some of them are youth, some of them are older, like in their 20s or so, and that's what they describe. Okay, next slide, please. Okay. So this is very common among Native American children, and understood that children under this one here. Okay, so about this, seeing things and hearing things. Many youth that are very young are, we know that for a long time they can see and sense things that everybody does anyway. Sometimes we'll see them sitting, looking in the corner, or looking at certain directions, laughing, or things like that. It's like they're talking to somebody that we ourselves don't see. But we've always known that these children are directly connected to the creator until they become more acquainted, connected, and safer in new physical environment. Part of that is that when a child is born, they believe that these children are directly connected till about the age of 7. And that over time, this kind of goes away as they become more acquainted with the earth. Old teachings might have them wear a leather strap on an ankle to help keeps the spirit from wandering, but also remembering that on the top of their head is there's a soft spot. But the older they get and the more closely they get to disconnecting with the creator, then that soft spot closes. So that's part of some of the teachings to be able to help people understand when they're working with Native Americans. So, I guess we are done with these slides. Are there any questions, comments? Let's see.
Thank you so much, Sean. Yeah, I lost the last slide there at the end, but just so folks know, we will make a copy of these available in a PDF format for you. So we'll include those in the follow-up email. A couple of people were asking about that. Sean, there was a question from Katana, and I think Harold also chimed in on this about Native patients being reluctant to reach out because they're not 100% sober. I don't know if Katana or Harold wanted to unmute and comment on that and see if you could address that.
Yeah, that's fine. I mean, a lot of times if you find the right people, because a lot of times there are those who say, well, they can attend ceremonies, but they cannot be using. And a lot of times they might want to have that person free from any substances for like so many couple days or something like that. A lot of times they want them clean for at least 1 day, 2 days, 3, 4 days, in order for them to be able to get some help at that time. But remember, there are different tribal practices that might be taken into consideration. As long as normally, as long as the person's not using, they can attend at the time. Hope that helps.
This is Deanna Pearl. I live here in Washington State.
Okay.
I work for the Cowles Indian tribe here in Washington, and my job is tobacco prevention and education coordinator, commercial tobacco and education coordinator. One of the things that I find, I was born and raised in a Native community. I'm non-Native, but I'm very aware because of my family. But one of the things I have here is the tribe here has been dispersed for many years, and they were able to come back together because they're recognized. I work with a lot of people who just assume because they're Native, they have a cultural practice. And one of the things I strive in my work is I ask them about if they have a cultural practice, religion, Christianity, what have you. And It's been very surprising some of my colleagues who just assume. And one of the things I do to train, I train people in basic tobacco intervention skills training for Native communities. And we spend a lot of time with that concept and having people, non-native people understand, or people who even serve with native people understanding that we just can't assume that they're all going to be on the red road or they all have, what have you. And I think it's been profound in my teachings and working with other people. If you have any other suggestions about how to approach that subject, I really appreciate
Well, I know that a lot of tribes do things very differently. But we also need to look at is that some tribes have lost more than others. And right now there's a lot of different tribal peoples and stuff like that adopting cultural ways from other tribes, especially if they've lost a lot. And that in itself, it can be an issue. But at the same time, if as long as they're looking more into those cultures and learning from it properly, because it's important not to just mix a bunch of different ways together, because then you don't get these traditional teachings and knowledge and stuff that you would normally get. Making sure you're not mixing things, that can be difficult. But it's important to be able to get as much knowledge as they possibly can. And a lot of times there are tribes who help out with other tribes to be able to, if they've lost so much, to be able to help them to understand those ways. Sometimes seeking out a medicine person, even one that's as close to your tribe as possible, is very helpful, because a lot of times they have very similar beliefs and different similar practices. And that might be an idea to look at. Hope that helps.
Yes, I see Char Green Maximo has a comment that she just posted. I don't know, Char, if you're comfortable unmuting and maybe sharing that.
Yeah.
Hi.
So I live in Sioux Falls, South Dakota. So I grew up a lot in, being in an urban environment. And I think something that's unique when you're in urban areas is that, a lot of times people are not around their cultural teachings or around their family directly. And so people just assume that they don't want to be a part of these cultural teachings or knowledge. And it just might be that they just never been exposed to them, or they've had a bad experience with people being judgmental. And so I think it's very important that we always continuously offer cultural activities and knowledge and activities for people to come to, even if it's something that they might seem like right away might not be open to. But I think, once you develop that relationship and keep encouraging that, they might come around. Because even if we haven't been around it, our spirit knows, like you can feel it when you're around a drum or you hear a singer, or when you hear those stories. So it's just something to be mindful about when you, a lot of times people might seem like they're distant from it, and there might be a lot of factors behind the reason why they're might be that way or come off that way.
Mm-hmm. Yeah, I know that when I was young, I used to get in trouble a lot. I like to ask questions. So the elders would always get mad at me and asking questions and said, "You're not supposed to ask elders questions." But over many years of getting in trouble, I finally found somebody that said, "Look, I'm not trying to cause problems. I'm just trying to understand, because many times you guys tell us it's like, well, the younger people don't understand and nobody wants to learn these things." But it's like I told him every time I ask more about it, I get in trouble. And he kind of looked at me strange. I said, well, someone would say, you're not supposed to ask your elders questions. And he said, oh, okay, I get it. So And I think describing things and looking at the history a little bit and describing to them what's been going on is that sometimes that's very helpful in helping them understand from your own point of view. So, it's okay. I mean, everybody starts at a certain kind of point, and that it's let them know that we're very interested in wanting to learn these things. That should be what they want to hear. So.
This is Monica, Yellow Owl, Klamath Tribes, Southern Oregon. Hi, folks. I know a few people on here. Good to see. This is just a thought I had as you were sharing that one slide about clinicians identifying clients by terminology like addicts or alcoholics, and just kind of looking at a more decolonized way to identify them. It's interesting to me, though, how the NA and AA culture really is like defined by like even the introduction of somebody. So for example, like I'm Jane Doe. Hello, good morning. I'm Jay Doe. I'm an alcoholic. And it's interesting to me that I'll see some of our indigenous people who've been in sobriety for a really long time, like 20, 30, 40 years of sobriety, continue to introduce through that lens of being an alcoholic. And so I think even in the recovery world, it's this conflicting message. Like we learn about statements like what you think you become, um, but we continually, there are cultures out there that are recovery based that this is the culture you identify yourself as. You never stop identifying yourself as that. And I think as we move to indigenize our recovery, or claim our cultural practices more and more, I think there's important work around especially in the recovery world. Maybe on treatment plans there is a treatment goal of how do you learn to introduce yourself in your own language. How do you go into circles and introduce yourself in a different manner. And I think it's just a way to strengthen, like we're building a new identity. We don't have to always self-define ourselves by the diseases that we have. And it's just interesting, absolutely no disrespect to AA or NA whatsoever. I never sought sobriety in those circles, so I couldn't say that I'm part of that culture, but I see it here, like in my own community, and it's sort of carried into the Wellbriety circles as well. So if I attend like a Wellbriety event or a Wellbriety circle, I notice that they've taken on that culture as well. And that's really interesting to me, and just wondering if anybody out there in the field of substance abuse treatment is working with their clients to decolonize even that introduction of self.
Yeah, I think that is very important, Monica. I know that Steve had said that when if let's say he was to introduce himself, he would say that he's Steve, but then say a person of long-term recovery. And myself, I've always been worried and trying to be careful of saying I am in any negative fashion at all. Because a lot of times what they say is that saying I am should only be used positively, because then you're creating that within yourself. If you say I am and it's something negative, you also create that. So I think a lot of those things come from different kind of belief systems sometimes, because I know that I like to learn from all cultures. I like to learn and look for similarities of cultures. I've kind of found it, to me, very interesting, and kind of a lifelong kind of learner of many cultures and their belief systems. But I do agree with many of who said that, is to say I am only in a positive way. And I think that with what Steve was kind of mentioning, it really does make sense. If, like I said, my name is Sean, I am a member of the Meskwaki tribe, but I want to let you know I'm let's say a person in long-term recovery or something like that. I mean, that might be something a little bit different because then you're remembering who you are. And I hope that helps.
I wanted to follow up on, this is Katana. I made a comment about your slide about the dark shadow man.
Okay.
So a while ago on my reservation, I started noticing a lot of youth. Well, first it changed my question. So when I would ask about auditory and visual hallucinations, I would just ask it like that. And then I started noticing a lot of youth were mentioning that dark shadow. So my question now changed to auditory visual hallucinations, not in a cultural manner. And that really clears up a lot with a lot of my patients. I work at IHS, so I only work with those eligible for IHS. But anyways, back to my story. So youth were mentioning that a lot, and I reached out to one of our spiritual leaders in our community, and I was like, gosh, what is this about? Like, because it scared me. It actually really scared me because so many youth were saying it, and I didn't really know how to handle it. And it was like, oh my gosh, does this mean like if I get in some kind of situation, is this going to happen to me? So anyways, I reached out to a spiritual leader, and he explained it as like a spirit of suicide. So like depression, suicide, anxiety, they all have their own spirits. And so when you're not balanced, then these darker spirits can come through. And I wrote down some other stuff, but I use that a lot. What he told me when I explain it to whoever sees it, not just youth. And I think that really helps them because they don't feel like they're going crazy, or they don't feel like, I don't know, they feel like they're being validated or heard or something. But I also want to add on the other side is I have seen a youth with a diagnosis of schizophrenia. And when I read the note, I instantly was like, no way. I don't agree with this. And I know that you're a psychiatrist, but I don't agree with this. And so I worked hard with the family to address that because I thought it was a misdiagnosis. And I mean, it's in his chart forever. That's what's difficult about those diagnoses. And that's where I still struggle with myself, even though I'm a clinical person with those. So anyways, just wanted to share, comment further. Thank you.
Katana. That I'm glad more people are out there trying to help natives in understanding a lot of this, and that even with clinicians, doctors, psychiatrists, it's like looking in from a different culture. They might not see our culture as unique or different from more different spiritually, except different, because a lot of times, natives do sense things, hear things, see things. It's, to us, is very normal. But the biggest thing is not to be afraid of it, because we're being shown things for a reason. And that, it can be difficult. I've tried to help as many people as I can when they try to ask for assistance and stuff like that. I've had to go on and talk to doctors, psychiatrists, different people to be able to help to incorporate more of our cultural ways. And because even in the DSM, it says to look at the client, family, and community. And they're supposed to take our culture into account.
Well, I know I want to honor everyone's time, including Sean's. I know we're just past the top of the hour, and we've reached our allotted time and gone a little past. But I really do appreciate, Sean, you coming on today and sharing some of your knowledge and information. We're going to make these slides available to you all in a PDF format. So look for that in your follow-up. And you can also request CEUs, either social work or NADAC approved. You can request that when you receive your follow-up email. I want to just again thank everyone. We're going to conclude today's broadcast. We're going to be on next month. Be the first. I think it's March 2nd. We're going to do an extended broadcast on ethics and professional responsibilities. You can apply this. We're going to try and make it a 3-hour event so that you can apply all 3 hours to your ethics requirements for certification or licensure. So watch for that invite. We'd love to have you back and help you get some of those CEUs that are required in most states. So love to have you back. Thank you again, Sean. And thank you for everyone in attendance today. It's great to see everyone. Until next time, stay safe, stay healthy, and stay connected. Thank you.